Hi guys, welcome in. Good morning, good evening, depending on where you guys are joining from. I know that we always have people joining our webinars from all over the country, which is one of my favorite parts about doing these. Today we are going to be talking specifically about neuro assessments in aging. And geriatrics is my population. My name's Annalise or Annie. I go by Annie. I did my undergrad, minored in geriatrics in nursing school, and then also in grad school, that was the population that I worked the most with as a family provider. So I really love our old people. My grandparents always joke that I was born in the wrong generation and I have a very old soul. So it is fun for me to be able to talk to you guys about this because there's a lot of health needs that they have, and there's a lot that we can do assessment wise as far as we talk about like health assessment, fundamentals, geriatrics from a beginning basis to help manage quality of life. Because remember, as we get older as nurses, one of our biggest and most important things that we do is we make sure that quality of life is good in this population. I mean, if you live to be 150 years old, because medicine has advanced so far that we can keep people alive for that long, but your quality of life is terrible, I would say that most people would not prefer to still be living. No one wants to be 150, but not be able to get out of bed, not be able to eat the foods they love or do the things they love with the people they love. And so, really, we worry about quality of life. And that is going to be where neuro assessments are so important. I like to think of it this way. If you imagine that you are taking care of an 80-year-old client and all of a sudden they become super confused and agitated. Well, you've got really two main options that you're looking at. You try to say, are is this dementia? Is their neurocognitive function declining and they're not going to get that back? Or is it delirium? This is an acute thing. It could be a UTI. It could be, sepsis. It could be anything like that. And is that going to be an acute issue? So really being able to quickly evaluate whether something's, acute or chronic, if it's going to continue worsening and they're not going to be able to get that function back, that is going to be life-saving. And so that's why this is a really important webinar we're going to talk about today. And we're going to go over some of the specific neuro assessments that we do that are going to give you more information. And today we have Jennifer here on chat support. So if any of you guys have questions, feel free to drop them in the chat or in the Q&A section. Jennifer is going to answer them for you. Of course, please do try to be patient. We're not going to use the raising hand feature today because there are so many of you guys here. But if you have a question, feel free to drop it in there. I'll try to keep my eye on it, see if I see anything that I want to answer live for you guys. But other than that, Jennifer is going to be answering them for you. And she's not a robot. She is very sweet and we love Jennifer. So be kind and patient and give her just a second to get back with some responses for you guys. So we will go ahead and get started. Okay. First thing I want to talk to you guys about is nursing school, though, because I am a geriatrics professor. I teach your geriatrics course. I teach health assessment and fundamentals as well for Archer for nursing school. But geriatrics is my love and my passion. And that is one of the 20 courses we created for you guys in nursing school. Because in nursing school, you guys learn so much. Jennifer was in nursing school. I was in nursing school. We're all nurses here at Archer. And we just remembered that nursing school is a lot of information really fast, and that can be very overwhelming. So we thought, what can we do to help nursing students as they're in the program, or even after they graduate, as they're starting a new job, or as they're, studying for the NCLEX, and they feel like maybe they need to go over some certain courses more than others. So we made 20 courses. Any course you take in nursing school, we're going to have a course built out for you in Archer for nursing school. In fact, we even have some courses that you'll never take a class in nursing school, but it's information that you have to know that you're going to get taught in nursing school. ABGs is a great example of that. We have made an entire ABG course for you guys to take to help supplement the learning you're getting about ABGs in your different courses, because whether something's compensated or uncompensated can be really confusing. So we made a whole nursing course for that. Lab values. How about dosage calculation? We have an entire course for that for you guys. And in those courses, we've made mini lectures because I remember sitting in a lecture hall for nursing school for like 3 hours. I'd get like a 3-hour pharmacology lecture. I don't know if any of you guys in nursing school are having that same experience. And then I'd go home and my brain would be melted. I'd be like, I don't even know what I learned. I just talked about like heart failure drugs, hypertensive drugs, like anything to do with the heart for 3 hours. It's so many different medications. So with that, what we've done is we've broken them down into really small lectures for you guys. So what you can have now is you can have a lecture, for 5 minutes on heart failure drugs, or, 10 minutes on this antihypertensive drug, just so that everything's really manageable for you guys. And then we made a bunch of questions for you guys to help prep for your nursing exams and for NCLEX. There's over 5,000 questions in the Q Bank. And then 1-page cheat sheets. These are medical illustrations. Our medical illustrator colored them, and there's tables in them, and there's mnemonics, and there's memory cues. And so with that, I like to print them out and keep them so that we have, something that is just really a condensed version of the most important information that you need to know. So that's really just an overlook at what Archer for Nursing School is. It's free all the way from now until January 1st, through the end of the year, it's free. So you can sign up here with this QR code. If you scan this, you can sign up for all the courses for free. And then also you can just go to the link if that's easier for you guys. But while it's free and while it's available, please do take advantage of that. We wanted things to be as affordable and as accessible for all nursing students wherever you are, because we know that that is a time where people are living off of top ramen and they're stressed because they're taking care of family or they're trying to have a social life. There's a lot going on in nursing school. And so we have tried to make this as easy for you guys so that you feel the most prepared possible. And that's my pitch for nursing school, because I, of course, helped build out this product. And so it is near and dear to my heart and I love it. So give it a go and let us know what you guys think. You can even drop in the chat if you're already using nursing school. Let us know how you like it. We're always looking for feedback. Okay, now to get into the meat and potatoes, as they say, of our webinar today. What are neurocognitive disorders? Well, really, when we look at neurocognitive conditions, what I'm talking about is any decline in cognition. So, neuro, so neural, and then cognitive, so cognition. Any decline in that, it's going to affect any aspect of it. Because remember, oh, Sylvia just asked when nursing school is free until. That is through the end of the year, Sylvia, just as a jumping back to that, through December 31st, you can go ahead and get that free. So all of the courses are free. You can go ahead and sign up now, give it a go. And then even after it's not free, we have made it super, super affordable. So I think it's, just about $200 for a full 2 years. So for your entire nursing school program, access to all of the courses is going to be just, under $200. So we really did try to make it as affordable as possible. Okay, back to neurocognitive conditions. Any decline in any aspect of cognition, because remember, guys, our brains do a lot of cool things. And so when you're talking about a neurocognitive condition, we're not just talking about, all of a sudden they can't speak and they don't remember anything and they can't pay attention. Like, it doesn't have to be all of them together. It can be really something that affects any of those. So if all of a sudden a client is having trouble, remembering how to speak their primary language, that could be a neurocognitive disorder. If it's their memory, that's what we often think of when we're talking about dementias. All of a sudden their memory's gone. Well, that could be a neurocognitive disorder. Any acute change in personality, all of a sudden, your grandpa's always been super sweet, super kind. All of a sudden he's really angry and swears a lot and mean. That could be a neurocognitive condition. It's just any change in cognition. And remember that cognition covers a vast amount of, it's our language abilities, it's our spatial awareness, it's our, visual capacity, it's our ability to interact with other people, it's our ability to feel emotions even. So that's why neurocognitive conditions are really all encompassing. And those are those common disorders down there that you're going to hear about the most, that you are probably all familiar to you guys at this point. That Alzheimer's disease, vascular dementia, Lewy body dementia, delirium. We have late onset dementia. We have early onset dementia. We have acute dementia that, starts on and comes on really fast. There's so many different types of neurocognitive conditions. And really, as we talk about the scope of a nurse, I don't need you guys to go into a client's room and say, oh yeah, they have Lewy body dementia, not vascular dementia. That is out of your scope of practice. You don't need to stress about that. I just list these so that you understand that there are a lot and that the impact is far reaching. And it's almost 10%, 8% of people in the United States over the age of 60 have some form of dementia. So if you think about that, if and it continues to increase every year. And people argue why that's happening. Is it because, we're testing more? For sure. Is it because people are living longer? For sure. Is it because of our diet? Maybe. There's a lot of different ideas out there for why we're getting more neurocognitive conditions. But regardless, it is more patients, more clients that we recognize have neurocognitive conditions, and that means we want to assess more. Once we get up to 10%, that's 1 in 10 elderly people over the 60 is not that old. My dad's almost 60. And so that is why it is so important that we understand how we assess these. And so when we talk about assessing them, there's some common testing. This webinar is never going to be all inclusive about neurocognitive assessments. I mean, you get a client into a neurologist and they have a billion different tests they're going to do, and they will go, so it will be like a couple hour-long appointments going into neurocognitive assessment. But for this, I'm just talking about what you as a nurse are going to see most commonly and are going to assess most commonly. So with that, one of the most frequently done is the mini mental status exam. You'll also see that abbreviated as the MMSE. So if you ever hear someone talking about the MMSE, that's the mini mental status exam. That, I think, is the most common way that we as nurses assess neurological cognitive disorders. It's pretty easy to do. It's just 11 questions that we ask, and it assesses their orientation. It assesses their memory, their attention, their language. It even assesses, some visual spatial aspects too. And when you're looking at the score for that, anything lower than a 24 is going to be some level of cognitive impairment. So, max score is 30, anything 24 or lower, you start to think about, this is someone who maybe has some cognitive impairment that we want to look at and to assess more. In addition to the MMSE, the other test that we have is the MoCA test. And the MoCA test, or the Montreal Cognitive Assessment, that focuses more on mild impairment. So someone who has never previously been diagnosed with any form of neurocognitive dysfunction, and, their family brings them in and they say, grandma all of a sudden is just forgetting things that seem, maybe not normal to forget. Or, she got lost on the way home from the grocery store that she's been shopping at for a long time. Maybe we want to start with a MoCA because it's very sensitive and it focuses more on that mild impairment. So you're going to miss less people with it. You can get, a better idea of people that have really new cognitive dysfunction that's not super severe at this point. And for that, any score of 25 or lower shows cognitive impairment. And then lastly, the quickest way to just a really quick check for patients like, you're just trying to get a general overview in the emergency department or in the ICU, and you just want to say like, hey, are they still with it? The clock drawing test, which actually is done in the MoCA test. That's going to assess visual spatial. So if you break that word down, I know nursing school terms can get really confusing. It's words that you don't normally use in your day-to-day language, and that can be overwhelming. But if you break it down, visual, so that sounds like visual. So eyeballs, what you see, and then spatial, how we look at things in space. Your ability to see dimension and things like that. And it also assess cognitive function. So for that one, I'm not going to talk about it too much in detail today during this webinar, but just so you know, the clock drawing test, you literally have them draw a clock and you tell them to put the hand somewhere. So I'll often say like, can you draw me a clock with all the 12 numbers on it? And then can you put the clock hands on 3 o'clock? Well, someone who has intact visual spatial awareness and executive functioning, they're going to be able to understand the command you gave them. That kind of goes into executive function. They can draw a clock, put all the numbers in the right spot, and then they will be able to put, the hands, the little hand on the 3 and the big hand on the 12, showing that it's 3 o'clock. I don't know if any of you guys have done a clock drawing test or seen a clock drawing test done on someone with pretty severe dementia or delirium. It's amazing. Like they will draw a circle. The 12 numbers will be all in one part of the circle or maybe not even in the right order. I've had patients draw me a clock drawing test where the 12 numbers are way far over to the right, not even anywhere near that. And so with that, it gives you a pretty good idea that there's something wrong if someone cannot draw a clock and put the hands in the right order. So these are kind of the 3 most common forms of testing. As we get a little bit more in depth for the MMSE, that mini mental status exam, or the MoCA, the Montreal Cognitive Assessment, people are always like, okay, Annie, you said these are 2 really popular neurocognitive assessments. Which one do I pick as a nurse? Well, first off, I want to be clear. It's often going to be facility protocol. So wherever you're working, we'll probably have a preference as to which form they use. Do they use the MMSE or do they use the MoCA? But if your facility lets you pick, or there's, some more variety about what you're allowed to use, The way that I like to decide which form I am giving my client is I talk about what are the benefits of the form and what applies more to my client. So the MMSE is less difficult. It's really fast to administer. So for someone that, you're short on time, they're short on time, and you just want to get a good idea of, how their neurocognitive functioning is, the MMSE is great. You can give it in like 5 minutes. That's really, really fast if you think about it. Additionally, it's not as hard of a test. So I'm sure as nursing students, you guys are all like, oh man, I would want to take the easier test. Me too. I would also always want to take the easier test, but that means that if someone has the very beginning stages of dementia or, Alzheimer's, they're going to get missed with the MMSE because it's not as hard. So those like just beginning stages of dementia often won't get caught by this kind of exam. So this is a better test for someone that comes into your floor and what? Jenny, she has dementia. We know that she has dementia. She's had Alzheimer's for 10 years. This is a really great form because it can track their progression. We compare these scores. We'll say, we assessed her 6 months ago and she got a 21 on the MMSE. Well, now 6 months later, we assess her again and she got a 19. So that lets us know from 6 months ago to now, their score has decreased this many points. So it really helps us track progression. Once again, on the MMSE, 30 points is your max. We're going to look at orientation, their registration, their attention, and their calculation, their recall, language, visual, spatial. And I list all those out. You don't need to memorize those really. But why I list those out is to let you know that that is how many parts of cognitive functioning we have. That's how much our brain does. It does a ton of stuff for us. The MoCA assessment, very, very similar to the MMSE, guys. These tests are not very different. They're pretty similar in a lot of ways. The MoCA is known to be more sensitive than the MMSE. And remember, if you guys have taken fundamentals or your community health course, you may have learned these terms, sensitive or specific. How specific is a test and how sensitive is a test? I have graduated with my doctorate at this point. Those concepts still confusing to me. I still trip those up, whether a test is specific or whether it is sensitive. The MoCA is a sensitive test. That means that you have very few false negatives. And remember, a false negative means it misses someone. So the way I like to think about this is I know the MoCA test is harder. It's harder than the MMSE. And so that means more people are going to fail it. If you think about a nursing school test, it works in the same way. So a nursing school test that is harder, more people in your class are going to fail it than a nursing school test that is easier. And so that means that it is going to miss very few people that have dementia. But it may tend to have a lot of false positives is what we say. So, it's going to tell you if you assess 50 people, it may say that 25 of those people have some version of dementia, of cognitive impairment. That may not actually be true. If you do further testing on those 25 people, it may end up that 10 of those 25 people, just were having a bad day. They were really stressed out. They didn't sleep well the night before. English isn't their primary language. And so that's why they failed the test. And only 15 people actually have dementia. But for cases like dementia, a lot of people say it's better for us to, over analyze people and send more people to neurologists for further testing than to miss people. Because with dementia, as we talked about, it impacts so many aspects of quality of life that the last thing we'd want to do is accidentally miss someone who needed to be diagnosed. MoCA is also available in more languages. It was created out in Canada. That's where the Montreal comes from. So I know we tend to have a lot of students joining from Canada. This is one of the great things you guys contributed to medicine. I love this assessment. And they have also made sure that it is translated in a lot of languages. And remember, anytime we do an assessment, especially a written assessment in nursing, we want to make sure it is done in our client's primary language. It's not a fair assessment to assess someone in a secondary or, tertiary language for them. I am amazed at especially how many of our students speak multiple languages. English is not their first language and are amazing nurses. I only speak English. I took a couple years of Spanish and I wish I was fluent. I need to go back and learn more. But it's hard when it is not your primary language. English especially is known as being one of the hardest languages to learn. And so we want to make sure we give something in our client's language that we're using approved translators when doing it. Also, guys, just know the MoCA does take a little bit longer. few more questions. It's harder to do. It's same as nursing school. If a test is harder, you would assume it takes longer. So, but we're not talking a ton, 5 to 10 minutes for MMSE, 10 to 15 minutes for the MoCA. So it's not a huge difference. Either one, you're pretty much going to have time for. The nice thing that you only have to remember is that both the MMSE and the MoCA, both 30 points is the max. So that is what we're looking at there. The MMSE form is the one we're going to talk about today because it's my favorite, and I do think that it is the one most commonly used because a lot of times when you're doing a neurocognitive assessment, you're tracking progression. So I think this is going to be the form you see the most on your floors, but the MoCA also is very similar to this. So don't think I learned the MMSE today, I'm not going to know how to do the MoCA. They're very, very minimally different. I almost threw those slides in there too, but I don't think we're going to have time to touch on all of it. So if you want to look up the MoCA form, you can find it for free online. And trust me, you'll see how similar they are. This question is like the same on the MoCA. So remember, we assess all those different aspects of the MMSE: orientation, registration, attention and calculation, recall, language, and visual spatial. So in that, the very first question we look at is orientation. And so we are assessing how oriented our client is. We score each question individually as its little section. That's going to be the best way that we track things, especially because, for example, the first question we ask is, what's the year, season, month, date, and day? I went and updated this answer down here as this example for you guys this morning so that it would be for what today was. I had to look at a calendar to know what day it was. And it's not because I have a neurocognitive disorder. I think we just get so busy. It's easy to forget what day of the month it is. And so for some of these things, that's why we ask a lot of questions and we assess a lot of different things, because sometimes it may just be that someone is busy rather than the fact that they have an actual neurocognitive issue. So with that, you're giving about 10 seconds for each response. You'll let them just think about it for a second. We don't want to give them a ton of time because, if they spend 5 minutes thinking about what season it is, they didn't know the answer. But really, there's only 4 seasons, so they may just guess it right. They have a 25% chance of getting the answer correct, even if they don't know the answer. So just about 10 seconds. Someone should pretty easily be able to say, oh, it's fall. And then we look at the month, date, and year. So we know that it's November. We know it's the 22nd of Friday in 2024. So with that, if that was my answer, I would get 5 points. So that's the max amount of points you can get because we asked 5 questions, year, season, month, date, and day. 1 point for each of those correct answers, max of 5 for that question. So for example, if I said, oh, the year's 2023, it's the 22nd of November and it's a Saturday, I'm going to get 3 points. I missed the year and I missed the day of the week. So that's minus 2 points for that, and you'll record that number. With orientation, we also then assess location. So not only are they oriented to what time it is in the day, but are they oriented to where they are as a person? We call that often oriented to self. Do they know where they are and why they're here? So with that, we ask the country they're in, the state, town, building, and floor. Building and floor tends to be one of those on the MMSE are often switched out for other things if you're not doing it in a facility. If that's going to be a confusing question for the client, you can switch it out for other things. Like, do you know why you're here? Would be a great way to assess orientation. So know that this form can be adjusted a little bit when necessary. But for this, for example, you'd say, we're in the USA. We're in Phoenix, Arizona. That's where I am right now. We're at a hospital and we're on the 6th floor ICU. That would be someone who really is oriented to self. They know where they're at. Then you have MMSE assessment. Next, we move on to registration. So can they register things? The way that we do this is kind of, threefold. And the thing about the registration portion is that we come back to this question later. So with that, you want to be very clear when you do this on the fact that clients need to remember this for later, okay? This I like to think of as the teaching aspect of a further portion of the assessment. When we look at recall and registration go together. But if we want someone to recall something, we need to make sure that they were taught that in the first place. So that's where registration comes in. What you're going to do is you're going to teach them 3 items that you want them to try and remember for later in the assessment. So that's always the first thing I say to my client so that they know it's something they need to pay attention to. My boyfriend, bless his sweet soul, knows that if he wants my attention, because I'm always doing way too many things at once, that he has to really get my attention and say, Annie, look at me. I need you to remember this for later. Because otherwise, it's going in one ear, out the other. because I just get too busy in my day and I just move too fast. So you want to make that very clear to your client. I always say, I'm going to tell you 3 items. I want you to try and remember these items. Then you tell them the 3 items. They should be very common. Don't pick something that someone's like, what? I have never heard of that. Like, I've never used that weird kitchen utensil. Like they should be things like an apple, spider, and blanket. Those I put on this example because for some reason, those are the 3 that I pick. They tend to be things that are easy for clients to remember. People may associate them. So sometimes I like to do words that are easier to associate, like a picnic is what this makes me think of. You have a picnic blanket, you're eating your apple, and a spider crawls on your blanket. Those words are easy for me to recall because I have associated them in my brain. That's one of the weird ways human brains work. So you teach them the 3 words. You say apple, spider, blanket. It's also pretty easy to pick 3 words that are in the room with you. So if you're in a hospital bed, it's easy to pick objects that don't pick medical terms, but things that are in their room, like a TV, a bed, and slippers, because then that visual cue may help them recall later. Then you want them to remember those words. And in order to make sure that we know that they understood what we said, we have them repeat it back. So we say, I need you to remember 3 words I'm going to teach you. The 3 words are apple, spider, and blanket. And then you say, okay, can you repeat those words back to me? And your client's going to say, apple, spider, and blanket. And you say, oh, that's perfect. Great job. You did awesome. And then you tell them, we'll talk about those terms a little bit. For the scoring in this section, the scoring is a little bit weird, whether or not we count it. Of course, it's going to be 3 points as the max, and you just give them 1 point for each object they're able to say back. And so this is almost immediate recall, We're looking at immediate recall versus delayed recall. If I say apple, spider, blanket, can my client immediately after that say apple, spider, blanket? That is their immediate recall, their immediate memory. So 3 points for that, 1 point for each object. Then you look at attention and calculation. So with attention and calculation, what we do is we do what we call serial 7s. You have the client count forward by 7, but they can start wherever they want. So they don't need to start at 1 if that's harder for them. They could start at 70. They could start at, 41 and go 41, 48. That would be harder for my brain, but know that they don't miss points if they decide to count anywhere else. They're just going to pick where they want in, the whole range of numbers, and they're going to count forward by 7, and they stop after 5 answers. So even if they get the first 2 answers wrong and it gets them off scale, what you're going to do is after they've given 5 numbers, I like to write those numbers down. So I'll have a little, piece of paper and a pen, and I will just write down, okay, they said 1, they said 6. So that would not be correct. But then if 6 plus 7, if they get that next one correct, they would get a point for that. So this is a little bit of math both for your client and for you. But once they say 5 numbers, it's going to be, of course, once again, 5 points. If you guys are kind of getting the idea of how we score the MMSE, it's not as complex as it sounds, right? We had them give 5 answers for serial 7s, and they get 1 point for each correct number. So while 6 was not correct, if then they got the 7 after that correct, they can get a point for that one. So that is going to be attention and calculation. As a caveat to this one, serial 7s can be hard for some patients or clients that you have that, didn't graduate primary school. And I know that in today's day and age, that may seem crazy. You guys are all getting, you guys are getting degrees. You're becoming nurses. So you may say, what do you mean someone didn't graduate primary school? Well, in the older generation and in some countries, that can be fairly common, especially if someone had to drop out of school because they had sick family members, they were homeless, they had to go get a job to help support their family. We need to be very aware of different cultures and of different backgrounds and socioeconomic statuses. That means that you actually very well may have clients that have not done primary school. So that is always something I ask first off. I ask, where they're from. I ask what their primary language is, and I ask what their educational background is. You may have a client who got their PhD and has been a professor for 20 years, but you also may have a client who, dropped out of elementary school after 3rd grade here in the States. And so counting by serial 7s may be hard for them, not because they have a neurocognitive disorder, but because they were never taught that. And so the MMSE and the MoCA assessment both have different ways we can assess that in individuals who that may be hard for. The most common way to do it on the MMSE form for people that are not good at math or, never learned to count is spelling world backwards. So the word world is hard for me to say, but that is the most common word done. And we just have them spell it forwards and backwards. You have them spell it forwards just to make sure that they know how to spell it. I'm an awful speller. Like if someone, world is an easier word, but if someone told me to spell like believe, I always get those I's and E's mixed up. So that would be a harder one. We try to pick an easier word, but you want it to be 5 letters, of course, because remember, we give 5 points for this answer. So you want a 5-letter word. You're going to have them spell it forward. So then they'll say, okay, world, that's WORLD, and then have them spell it backwards and go, okay, world backwards. That's DLROW. I mean, that actually was kind of hard for me when I just did that here at this webinar. They can write it down if they need to and then spell it backwards for you. So that is going to be one of the things we do to be aware of our specific clients with specific backgrounds. Now we have recall. So really, we have just put one form of this test, attention calculation, in between our registration and our recall. So with that, with recall, this is going to be delayed recall, I think is a better term for it, because we did immediate recall. Now you're just going to say, hey, remember those 3 words I taught you? Do you remember any of those? Can you repeat those back to me? I should have, before I moved on to the screen, see how many of you guys could comment the 3 things we talked about. Because I would have been, it's pretty easy when you're taking notes, you're stressed out, you're trying to memorize everything about the MMSE form to remember something small like 3 words. So I don't know, maybe you guys did remember this, but you just ask them to repeat back the 3 words. And once again, it's going to be 3 more points. So 1 point for each of the 3 items they got correct. So maybe they say, oh, it's an apple, a blanket. Oh, what was that 3rd word? Oh, it's a basket. Well, basket's wrong. They'll get 2 points for getting apple and blanket, and they'll miss 1 for missing spider. Now we move on to language. Language, it gets more complex. As you guys can see, this is the one with the most steps. When we talk about language, remember there's some different aspects of language that we assess. We want to assess a client's ability to underhear us. So that's kind of like almost hearing, do they understand what we're saying to them? And then also, can they follow through with it? So do they have that executive functioning where, we tell them to do something and they can follow the command? Did what we were saying make sense? Remember, we've got those 2 types of aphasia. We've got Broca's aphasia and we have Wernicke's aphasia. So we have those 2 different types that, one affects your ability to understand language, one affects your ability to speak language. And so we want to assess both of those. Do they understand what we're saying? But also, can we understand what they're saying? Those are 2 different aspects of language. So with that, what we do is we give the client a little mini pop quiz. You hold up an object and you say, what is this? Do I even have a pencil on my desk? I don't even have one. I almost always have a pen or a pencil in my scrubs because we do so much writing as nurses. I'll just hold up my pen and I'll say, what is this? Well, if they can tell us what they are, we get a point for that. So correct point. Then you're going to hold up something else and have them say what it is. So we assess 2 different forms on a pop quiz. You'll hold up 2 objects. You'll say, okay, what's this? Oh, that's a water bottle. What's this? Okay, that's a pen. They get 2 points for each of, so they got 1 point for the water bottle, 1 point for the pen. Then you're going to have them repeat phrases. So now we're assessing their ability to speak language. The holding up the pen and the watch aspect, that assesses a couple different things because we can understand what they say back to us. And also it's, what's the term for that? I wonder if Jennifer can comment it for you guys. I'm having a mind blank. I cannot remember. That is our ability to recognize things. It's not stereognosis because that's like when your eyes are closed. I can't remember the term now. But we should be able to recognize things. Some people can get what we call like face blindness, where all of a sudden they can't recognize themselves in a mirror or other people. That would be a neurocognitive disorder that we would want to catch. So if you hold up a water bottle and they say, oh yeah, that's an apple, that would be concerning. Okay, agnosia. Jennifer is correct. Okay, Jennifer has got the term. Thank you, Jennifer. See, this is why we love Jennifer and that she's not a robot, because she comes through for me when I'm forgetting terms. Agnosia is the term when they can't recognize something. They see things and it doesn't make sense to them. They can't, say what that is. They get confused. So if you hold up a water bottle and they say that's an apple, concerning. Write that down, and that's going to need to be further assessed later. So we do those 2. Then we have them repeat a phrase. So just pick a common phrase. No ifs, ands, or buts is one that I do a lot. I'll often say, all my eggs in a basket, happy birthday. Just any sort of phrase that sometimes I'll say something, especially if I'm assessing like a kid that we know has had brain trauma. I'll try to pick something that's funny, make it engaging. Obviously, don't pick anything inappropriate or that would be offensive. You want to just pick a common phrase and have them repeat it back. So you say, I'm going to say a phrase. I want you to listen to it and then just repeat back what I say. So I say, no ifs, ands, or buts. Then I have my client repeat back. They say, no ifs, ands, or buts. And there we go. That is going to be letting me know that they are good there. Their language is understandable. I have assessed clients with the MMSE before that had, agnosia. They had different types of aphasia. They couldn't speak. And I would say no ifs, ands, or buts. And they just blah, 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 like no words at all. And then they look at you like, are you dumb? Like I just said the same thing you said. They didn't understand that what they were saying was not in English or, in the language we're speaking. So that is something to assess. Then we want them to write a complete sentence. So can they write down a sentence? I want an apple. I'll write that down. You want to assess that they can write that. Once again, in an individual who didn't finish primary school, didn't learn the alphabet, doesn't know how to write or read, this is not an appropriate question for them because they're going to fail. They don't know how to write or read. But most individuals, of course, the vast majority of patients and clients that you assess are going to be able to write and read. And so with that, you're just going to have them write down that complete sentence. It doesn't need to be a paragraph. I'm not writing a poem and having them transcribe my poem. Just a sentence, an easy sentence, whatever you want. Then you're going to have them copy a design on a piece of paper. So, I often will just make a square or I'll draw a circle or a triangle. A cross is a really common one. Keep it simple. You don't need to be drawing, a cathedral and having them copy that out, especially I'm sure some of you guys are very artistic. I am not super artistic, so I'm not a great artist. I would not want someone to, draw like a whole sailboat or something. Just keep it simple, a shape. Just copy that design down and then say, can you draw this as well? So can they see what you drew and they can also draw it. And then lastly, this last part of language here is you're going to have them read a phrase. So I will have a piece of paper and on that will say, close your eyes or stand up, something like that. That's an action. You have them read it and then tell them to do what it says. If you don't tell them to do what it says, and that you can't really dock them for it, because if someone handed me a piece of paper and I said, close your eyes, I wouldn't know that I needed to obey that command. So make sure you're making that clear ahead of time. You tell them, okay, I'm going to have you read this out loud and then do what it says. So they'll say, close your eyes, then they'll close their eyes. Or if it says stand up, then they'll stand up out of their chair. That is a really big portion of executive functioning, that they can follow commands. So there are 6 things we just did there. We held up 2 items and had them say what it was. We had them repeat a phrase that we said. We had them write out a sentence. We had them copy a design. And then lastly, we had them do something that we told them to that was written down. So they get 6 points for that, 1 for each of those things that they did correct. Then there's this 7th aspect of the language assessment in the MMSE that kind of gets mixed, it kind of gets missed pretty often. It is a 3-stage command. So you get 3 points for this aspect of the test. So, the first 6, you just get 1 for each of them. And then number 7 is a 3-pointer because they're following 3 stages of a command. The very most common way to do this is to tell them, take this piece of paper, fold it in half, and put it on the floor. So that you see the 3 stages of that command. It's to take the paper, fold it in half. That's the second command, and then place it on the floor. You could pick other things if you didn't have a piece of paper, if your client had really bad mobility and putting something on the floor was going to be harder for them. You can go ahead and pick whatever 3-stage command you want. That's just the one that the MMSE recommends and is the most commonly done. Of course, then they're going to get max 3 points, 1 point for each of those commands that they follow. So taking the paper from you, they get a point for that. They get a point for folding the paper in half. And then they get a point for putting that piece of paper on the floor. Okay, that was a long one. Language is the one that we assess the most things in because we want to know, can they read? Can they see? Can they repeat back? Can they speak English? Can they follow a command? So that is really the most complex one. And that is where we finished. So remember now, we've assessed their language, their recall, attention calculation, their registration, and their orientation. So that is the whole test. What you're going to do then is just add up those scores and we'll look at the scoring. But I want to talk first about some specific client adjustments. We've already kind of touched on some of these as we did this test, because there are some ways that we change the test for individuals that may struggle in some of these aspects. For example, you want to account for their language level and their culture. Don't pick something that maybe doesn't make sense to them. Some cultures don't celebrate holidays. I used to pick holidays pretty frequently. I'd say, like, what's the next holiday coming up when assessing cognition? Well, we're about to celebrate Thanksgiving here in the United States. Canada's Thanksgiving is a totally different day. And some cultures don't celebrate Thanksgiving at all. That is an American, and Canadian holiday. And so with that, you want to make sure that you know what a client's culture is, what their background is, so that you're not quizzing them on, it's October, Halloween's the next holiday. They don't say Halloween because they don't celebrate Halloween in their culture, their religion. And now you dock them for something that is not their fault. They didn't have poor cognition. It just wasn't an appropriate question for them. Does that make sense? Let me know if that was confusing for you guys in the chat. That is why we worry so much about their culture and about their education level. We talked about serial sevens already. If they didn't finish primary schooling, that can be a really hard question to ask. Second thing we want to talk about, I've already said this, you always administer the form in their primary language. So if their primary language is a language that you don't speak, get an approved translator, not their family, not their sibling, not their spouse, an actual translator at the hospital, and do it in their language. That often means you may need to use the MoCA instead of the MMSE, because the MoCA is available in more languages. We want to assess their cognition, not how well they understand the question. This is not supposed to be a trick quiz. After going through those questions, I hope you guys can see that it's supposed to be pretty cut and dry. We don't want them to do it and be like, okay, well, do I need to fold the paper hamburger or hot dog? Am I folding it horizontal or vertical? That doesn't matter. Just fold the paper in half. We're trying to keep this test as simple as possible. We want to know their understanding, not their, we want to understand their cognition, not their just understanding of the question. So we want to make that as easy as possible by putting it in their primary language. And then lastly, you want to make sure that you account for their level of consciousness. This we have not talked about yet, but this is probably one of the most important things you'll do. Because while most of your students, most of your clients are going to have finished primary schooling, level of consciousness is going to vary a ton. And so with that, for example, being tired, if someone did a cognition test on me the second I woke up from a nap or from sleeping, oh man, I'm failing that test. I promise you. I am dumb as a rock first thing in the morning when I wake up. You're kind of confused, especially if have you guys ever taken a nap? You like come home from a nursing lecture, you sit down on your couch to get comfortable, and then next thing you know, it's been like 2 hours and you've been asleep the whole time and you're really confused, you're really tired. That can be misinterpreted as cognitive impairment. So make sure that you understand that when you're assessing for cognitive, you're doing a neurocognitive assessment, you first check their level of consciousness. Are they awake and they're with you? Just yesterday, I made homemade brownies for a dinner party I was going to, and I put the brownies in the oven. I make these brownies all the time. I set the timer for 30 minutes because that's how long they're supposed to cook for. And then I went downstairs and started working. My timer went off, telling me that I need to take the brownies out of the oven. I turned my timer off, and then I just went back to work. Is that a neurocognitive disorder that I had? Some may argue yes. I let the brownies burn. I left them in there for 3 hours, guys. All of a sudden, I'm in my basement, and it just smells like burning chocolate. I was like, oh no, this is not good. I run upstairs. My brownies are brown to, they're burnt to a crisp. I had to start all over. I was really busy. My brain, just like I was telling you, my boyfriend has to get my attention. My brain was not with that activity. I was in the middle of working and I was editing questions for your guys' Q bank to try to make sure the Q bank was as perfect as possible for you guys. And so when my timer went off, I was busy. I just turned it off and went right back to work. You need to make sure that when you are assessing a client that there's no other distractors around them. That if you're going to assess them on how well they can follow a timer's instructions to take brownies out of the oven, that they're not also working at the same time. My concentration was split, and that is why I burnt my brownies, not because I had a neurocognitive disorder. So you want to make sure that when you're assessing clients that they're in a quiet space, that there's not distracted by other things, that they're not currently stressed out, they didn't just wake up from a nap. So those are all things you want to account for when administering this assessment. Now, that kind of gives it all to us. So we're done. Remember that 24 on the MMSE, 24 or below is considered to be mild impairment, and 25 or below on the MoCA is considered to be a form of impairment. You don't need to be the one that diagnoses dementia. You just need to be able to let a healthcare provider know, hey, I'm worried about their cognitive status. And, I performed a neurocognitive assessment and they scored low. That's good enough. You can pass that baton off for further testing. We're going to go ahead and do some practice questions now. But since we've kind of reached the end of our content about neurocognitive assessments, if any of you guys are still struggling with this or any other subject in nursing school, I want you to know that we do have private tutoring available. So you can go ahead and reach out to this email here, nursingschool@archerreview.com. We want every student to succeed, and that means that we recognize that some students don't learn at the same pace. It does not mean you're dumber. It does not mean you're going to be a bad nurse. It just means that sometimes people learn in different ways. Some people are visual learners, some people are auditory learners, some people are practice learners. There's so many different types of learning styles. It doesn't mean you're dumb. It doesn't mean you're going to fail the NCLEX. It just means you may need a little bit more guidance or a little bit of one-on-one time. And so with that, we offer private tutoring that's going to be totally individualized so that you can get that one-on-one contact with a tutor who's a specialist. Rebecca, for example, she is our ICU queen. She is so good at ICU. We've got Brandon, math whiz. If you got a dose calc question, you want to have tutoring from Brandon. Jennifer, maternal reproductive, that is her stuff. She is so good at mom and baby stuff. Me, I'm geriatrics. I'm health assessment. I'm fundamentals. I'm a family nurse practitioner. So all that basic introductory stuff. If you're struggling in health assessment or you're struggling in fundamentals, go ahead, scan this QR code, and we can go ahead and get you in for a 1-hour session as often as you need to make sure that you are succeeding in nursing school. We don't want any students to fail nursing school. Nursing school is not meant to fail. It's not supposed to be something you drop out of. You guys are all fully capable of succeeding. You may just need a little bit more help. Okay, moving on to our practice questions. Some tips and tricks. If you guys were in my cranial nerve webinar last week, you'll know that I like to start with tips and tricks first. I don't want to trick you guys, and I want you to go into these questions knowing what we're assessing for. So first off, remember, delirium is acute onset. So if anything ever talks about they just barely, this is an acute change. I want to go off warning bells in your head, delirium. And dementia is a gradual decline. I also work as a nurse practitioner, and I saw a patient last week who we knew had dementia. And this is where it starts to get confusing. They had dementia, and then all of a sudden the facility was complaining, she is just really her dementia is so bad right now. I think we need to move her to a memory care unit. This was at an assisted living facility. They were like, we need to move her over to memory care. And I was like, I mean, she definitely has dementia, but it hasn't been so bad the last, couple months. It's not like an acute change was setting off warning bells in my head. I was thinking, oh, this could be delirium. So I ordered a urinalysis on her. UTI came back positive. She had a UTI. So we treated that with an antibiotic, and the facility just called me yesterday evening to let me know she is so much better already. So know that sicknesses, illnesses, vitamin B12 deficiencies, low thyroid, sepsis, urinary tract infections, all of those can cause delirium. And that's going to be more of an acute change. So patients can have both dementia and delirium. You can have both at the same time. And so you want to make sure that you know, is this something that they've always struggled with and it's just slowly getting worse? That's going to be dementia. Or is this something that all of a sudden is a change in their cognitive status? Think delirium. Know the key tests, both for nursing school, for clinicals, and for real life and the NCLEX. You need to know the MMSE, you need to know the MoCA, and you need the clock drawing test. You don't need to know every single aspect of that test memorized. What I need you guys to know that those are neurocognitive assessments. That's going to be huge. And then lastly, test strategies. I need you to pay attention to things like symptoms. So if they say sudden confusion, gradual memory loss, that's going to be really key words that you need to pay attention to when you're deciding between something that is delirium or something that is dementia. Here's practice question 1. A 72-year-old client scores a 20 on the mini mental status exam. So the MMSE, they scored a 20. What is going to be your can't read English. Which of the following actions should the nurse take next? Do you want to document normal findings? Do you want to provide cognitive stimulation therapy? Do you want to educate the client on advanced directives? Or do you want to refer them for further evaluation? I'll give you guys just a few, a minute or so to look at this, and then go ahead and comment your answers below. Good job, guys. I'm seeing a lot of answers come in. Oh, it's good to know that I did really good teaching today. You guys are great. You're so smart. That is totally right. We are going to refer them for further evaluation. Remember, a 24 or lower indicates cognitive impairment on the MMSE. And so with that, the first thing you're going to want to do is get further evaluation. Cognitive stimulation therapy, that's going to be something that a healthcare provider would put the orders in for. So we're not going to do that as a nurse. Especially if they've never been diagnosed with dementia or anything, we wouldn't take that upon ourselves to make that decision. We would just want to know, hey, they scored a little low, showing kind of some mild impairment. We want some more testing done to see what's going on. So we know that's not normal finding, so we would cross that one out. We know that cognitive stimulation therapy, ordering that's not really in our scope. And then educating them on advanced directives, that is definitely something we want to do in all of our geriatric clients. So that's a good option, but it's not going to be the first thing we want to do, and we're not going to do it because they scored a 20. It's not like we're saying you want to be careful. Advanced directives can really stress a lot of clients out. That's an advanced directive kind of says what we want to happen. Do we want if we go into cardiac arrest, do we want CPR? Do we want a feeding tube? Who do we want to take care of our money? So it can be a really stressful conversation. It's a very important conversation to have with clients, but it can be stressful. So the last thing you want to do is have a client take a test, tell them they didn't perform well on the test, and then say, okay, it's time to decide how you want to die. Should we put you on hospice? Like that's going to stress someone out and make them really nervous. And so never lead into that right away. It may be a conversation we want to have. And I always, when I have that conversation with every one of my clients, I always start out and say, this is something we talk about with every single client, because you don't want to single them out or make them think that we think they're dying. And that's why we're having that conversation. We just say, as we get older, we want to make sure that everyone is comfortable and that you have what you want to happen to you later in life. So that, if you can't make decisions for yourself, that we're still following your wishes. And so this is a document that lets us document what your wishes are. That's kind of how I address every conversation. Okay. Practice question number 2. I think I've hit something. Here we go. Okay, here we go. Number 2. During a neurocognitive assessment using the clock drawing test, a client is unable to correctly place the numbers on the clock. Remember, we talked about that one earlier? This finding indicates impairment in which of the following areas? This is really calling back on a type of cognition that we talked about at the beginning of the lecture. Remember, I broke it down for you guys. Go ahead and comment down below what the clock drawing test is assessing. Oh, I'm seeing all those answers coming, guys. Great job. Perfect. Way to go, guys. That is visual spatial. So remember, it's their ability to put the numbers on the clock in the right spots. That is going to test visual spatial ability, visual spatial awareness. So that is often seen in neurocognitive disorders. That's why the clock drawing test is the easiest way for us to assess things. Remember, memory, speech, and attention we assess in different ways. That's not going to be the clock drawing test. So make sure that you understand when we're doing those assessments that we talked about, what we're testing. This immediate recall, is this, registration, is this orientation? Then this is our last question. We'll end here, guys. This one I made a little bit more difficult. It's a bit of a storyline for us to follow here. So you have a 79-year-old client. They're admitted with pneumonia. So we know they're sick. The client's daughter reports that her mother has been confused for the past 2 days, experiencing hallucinations, fluctuating alertness. They have a history of dementia. Oh, great. So now we're getting this question. It's gotten a little bit harder because we know they have dementia. But she says for the past 2 days, she's been having hallucinations and fluctuating alertness. Which of the following is the most likely to indicate delirium rather than a worsening of her dementia? Is it going to be a gradual decline in memory over the last year, fluctuating levels of consciousness over 2 days, difficulty recognizing family members for the past 6 months, or impaired judgment and decision-making over several months? I'll let you guys go ahead and comment the right answers for us. Oh my goodness, you guys are so smart. Bunch of smart cookies here. That is totally right. Let's break this down before we go on to the next one, though, in case anyone was a little bit confused about the right answer. So, what the stem of the questions. They gave us a lot of background that almost is unnecessary. And sometimes questions, while they're not meant to trick us, will give us information that is not pertinent to the actual stem of the question. So I always read that, the stem of the question, again after I've read the whole thing. So going back to the stem, what they actually want us to look for is which of the following most likely indicates delirium rather than a worsening of dementia. So what we're trying to do here is we're trying to decide what would be indicative of delirium rather than dementia. So what we need to look at is which of these answers is different than the other, because 3 of them are going to indicate dementia, and 1 of them, which is the right answer, is going to indicate delirium. So in A, we see the word gradual. Remember, gradual always makes us think dementia, not delirium. Fluctuating over 2 days, that sounds a little bit more acute. It's only been 2 days. That's making me think maybe delirium. Then you have C, difficulty recognizing members over 6 months. 6 months, that's pretty chronic. That's not, they just woke up one day and they don't recognize their spouse. And then lastly, decision-making difficulty over several months. Once again, that sounds chronic to me. So like you guys all said, the right answer is, of course, B, fluctuating levels of consciousness over 2 days. That is very indicative. Dementia is a stable decline. That's going to take months, years. I have had patients that have had dementia for 15 years, that just slowly they get worse and worse and worse. Delirium is an acute, sudden onset. It's fluctuating. And so that means that you want to make sure that if there is an answer, you've read the stem again, we know what we're looking for. Delirium and dementia, very similar words. So you may get this question wrong, not because you didn't understand the concepts, not because you didn't know the right answer, but because you read the question wrong. So make sure you are making that stem of the question very clear before you move on. Okay, the right answer is going to be the answer that indicates delirium. If you're still confused about what the stem of the question is, I always do that little tip and trick we just went over. That's find the answer that is different. 3 of those answers were all chronic and 1 was acute. So even if I didn't understand what the question was, I probably could have guessed that was going to be the right answer because it was the one answer that was different than the others. So that is just some test taking strategies for you guys. That is where we're ending today. April, that is so sweet. Thank you. That makes me feel so great. Very kind words. Say I'm a great teacher. These webinars are fun for me. I wish they were in person even because I love interacting with you guys and I definitely love teaching about geriatrics. So thank you so much. There was a ton of you guys here today. I hope that this was a good overview for you guys about neurocognitive assessments and how we perform them, but not only just how we perform them, but why we perform them, why it is so important that we monitor progression of neurocognitive disorders in our elderly clients. And just to be clear, you don't have to do this in just people over the age of 60 or 65. Neurocognitive assessments are used across the board. That's just going to be the most common population. Head injuries will often do these assessments. You can have early onset dementia that you get in your 40s. We're going to be using these assessments. So I will stay on here for just 1 more minute if anyone has any last questions they want me to answer about neurocognitive assessments. But other than that, thank you guys for joining today. Go ahead and sign up for nursing school. I'll go back to that first slide here with that QR code for anyone that wants to sign up for nursing school. It's free once again through the end of the year. You can see me. Oh, thank you, Caroline. If anyone wants to see me talk more, I'm a big hand mover. I teach fundamentals, I teach geriatrics, I teach health assessment in those courses. So you will hear me yap on for hours. Lots of videos to watch of me. Go ahead, sign up for free today. Thank you guys for joining. It has been wonderful. Oh, what is a good score? Real quick before you guys go, a good score, we don't really worry about good or bad when we're talking about neurocognitive assessments when it comes to scoring. We just look at what's the cutoff for what we consider to be cognitive impairment. So remember for the MMSE, 24 and lower is considered to be mild. It's considered to be where we start looking at cognitive impairment. We say, okay, you scored a 24. Remember, 30 is the max score you can get. So if you score 30 to 25, we're saying, okay, your cognition's fine. Once you score a 24 to 0 on the MMSE, we start to say there's, some semblance of cognitive impairment that we want to assess further. So I guess to answer your question, 25 to 30 would be considered a good score. We're not worried about that. Okay. Thank you guys so much for joining. Have a good day. If you're celebrating Thanksgiving, happy holidays. We're getting into the holiday season. Oh, in MoCA, the score it's 25 or lower is considered to be 25 or lower is considered to be cognitive impairment. Sorry, guys, my brain just frazzled out. So remember, the MoCA is a harder test. So that's how I remember that a higher score is considered cognitive impairment in the MoCA because, a 25 is considered cognitive impairment where a 24 is considered cognitive impairment in the MMSE because we're a little bit more sensitive. So that is everything, guys.